This is FX Medicine. I'm Andrew Whitfield Cook, and we're at the 2019 UIC Medical Cannabis Symposium. We're speaking with Dr. Jeffrey Hergenrather. Jeffrey, welcome, and how are you?
I'm well, thank you. Thanks so much for inviting me on here.
I so enjoyed speaking with you and interviewing you 2 years ago.
Thank you.
You've given a talk already. Tell us a little bit about that talk, because it's a very important message.
Well, it is an important message, and what I find in reading the literature and keeping up with literature on cannabis science is that the titles of articles and the headlines that often follow those are often looking for and suggesting harm in the use of cannabis. And as you really take these studies apart, you see that the evidence of harm just isn't there. So I like speaking about the harm versus the evidence because of the fact that in almost all cases, there's alleged harm that doesn't hold up to the scrutiny of the actual evidence. So, for example, yesterday I had a lot of participants appreciative of hearing more about brain damage and maternal, fetal, and neonatal harm. These are hot topics right now,
right?
And rightfully so. We don't want to be doing harm to infants and children and mothers and nursing babies. But as you really look at the evidence, in almost all cases, what we're seeing is that the use of alcohol and tobacco is confounding the evidence, because cannabis is very seldom separated from those other dangerous substances. And we know that moms using tobacco or moms using alcohol may be, in fact, damaging their fetus. And the evidence does come out showing that there is evidence of a variety of complications of pregnancy that are really problems of alcohol and tobacco and maybe other drugs, but not of cannabis. So the better quality studies we get in maternal and fetal development, the more we see it's not the cannabis that's the problem. Similarly, in the developing brain, studies will come out and say we're seeing evidence of the adolescent smoking cannabis having brain development that's quite different. They have smaller and misshapen organs in their brain.
Yeah.
Nucleus accumbens, hippocampus, these small organs in the brain. Well, again, if you control for alcohol, that difference disappears.
Oh, really?
It disappears. It's not there.
So cannabis is being blamed for illegal drugs action.
That's right.
On the brain. We've covered this ad nauseum, alcohol.
That's right.
And the two are commonly used because they're, alcohol is worldwide and very accepted, and cannabis is commonly used.
That's right.
Well, that's poor statistics then, isn't it? If they're not controlling for a variable.
Right.
Well, shouldn't they have seen that?
They do see that, and in a Gilman article that was supported by the National Institute on Drug Abuse, it's been about 4 years ago, Gilman came out and said, definitively, this is dangerous. This is damaging the development of the way that the brain works. And in the body, the text of the article, they'll admit that, in fact, the cannabis group of subjects that were using, smoking cannabis as adolescents were, in fact, using more alcohol. They said it wasn't an addictive amount, and they didn't think it was necessarily harmful. But the National Institute on Drug Abuse felt that, well, this is complicated. We need to re-look at this study. So a year later, the Weiland study came out, also funded by NIDA, and now they controlled for alcohol much better.
Right.
And so they had 29 adults and 50 youth, adolescents, and controls of the same numbers, and they looked at the evidence in their brains and saw no evidence of any changes in the brain structures.
And so what's the proposed future study? Larger numbers?
I suppose that would make sense. It's just get larger numbers.
Again, trying to look for damage.
Trying to look for damage. So it's one thing is to look for evidence of physical damage, and there's another aspect of, is this actually causing anything in terms of IQ or cognitive abilities or grade point averages? And again, when you control for alcohol and tobacco, we're not seeing any evidence of harm.
Okay, but we see with other drugs, there's various restrictions on certain groups, pregnant women, youth, whatever, the medical profession mistakenly used, drugs causing suicide in, for instance, attention deficit disorder children. So they found very poor outcomes as they grew up. We've made those mistakes, and then guidelines change. Mm-hmm. What if there was a backward sort of reverse engineering way, and used medicinal cannabis, let's say restricting its use mainly in adults to start, and those children that lead with epilepsy, and then looked at other groups once the safety data came out? Couldn't they do that?
Yes, we could design studies differently. We've tended to think that the only way to do a study is a randomly controlled study. And I like the concept, and in many cases that's appropriate. But cannabis is not so easy to do a randomized control study, either in terms of getting approval to do it, which is almost impossible, almost impossible. But there's another aspect of it is people know if it's real cannabis or not. You're not really blinding these subjects. It's almost impossible to blind the subjects.
So this is like the famous Smith and Pell study published in, BMJ 2001 or something, but they were trying to control for a placebo effect of parachute jumping out of a plane. So who wants to go without a parachute? Not going to happen.
I get you.
So we need the safety data, but are we losing our way? Are we concentrating too much on trying to find a danger? I mean, it seems like there's design behind that. Is that what you think's happening?
No, I completely agree with you. I think we're missing the point. At this place in time, after so many millions, maybe billions of dollars have gone into research looking for harm, we ought to step back a bit and say, wait a second. We're not seeing any overt evidence of harm. Maybe we should be looking at how these people are really doing. Design the studies differently. Combine N of 1 studies. You'll find people in high places that are regular cannabis users, and they're invisible in our society. So in my practice, for example, I've got doctors and lawyers and justices in the courts and many professionals that are using cannabis successfully, and you would never know them in society. Of course, as a physician, I can't speak of any specifics.
No.
But people are just frankly quite unaware of the fact that cannabis is used throughout society, probably even here in Australia, and you wouldn't know it.
Definitely here in Australia.
Definitely.
It's definitely is.
Definitely here.
I mean, this is the whole thing about, there are people in need. One of the things that really pulls at my heartstrings is children who they can't be controlled. Their fits particularly, they can't be controlled by adequately, or if they can't be controlled adequately by their medical regimen, then they really need this help, and it works for a large portion of them. So, I don't get it as a health professional, why there's something that's been shown to be a benefit, it's shown to do no harm or very little harm, and it helps them. And we say we've got, access, but we already know that it's a broken system leading to reintroduction into the black market because it's too costly. They're afraid of being criminalised. What do you think needs to happen?
Well, it's probably not the right subject for the talk, but eventually I think we have to free the plant and decriminalize it and allow people to experiment and use it for themselves. Now, having said that, we also know from a conference like this that cannabis is not one thing.
Yes, this is the problem with
there
medicine.
Are hundreds and hundreds of different strains, and as you break them down into their constituents, you see quite a different array of active molecules from strain to strain. So there was a brilliant presentation this morning by Dr. Meary showing that when people start on anti-epileptic drugs, something around a quarter of them will get good control right off. And some of them get some control, but not great control. If they go on to 2 drugs, 3 drugs, then they're allowed to finally access cannabis. And so of that last 25% of children with seizures, those are the ones that didn't respond to 3 drugs.
Yeah.
And so if given an opportunity to use cannabis, the first try of cannabis, you're going to get control of about another third of those that can't be controlled with conventional medicines.
Yeah.
And then if you actually look at those details of the other cannabinoids, those other chemovars we're liking to call them now, you may be able to select for ones that in animal models controlled seizures, give those drugs, give that medicine, cannabis medicine, to these refractory epilepsy patients and get control of another big portion of those patients that we haven't been able to get control. In many cases, the study designs don't really want to find benefit in cannabis.
Right.
So it's one strain used and maybe a fixed dose, maybe a variable dose, but if it doesn't work, then that's the evidence they were looking for. They're not really trying to take care of people.
So it shows either ignorance or mischief.
Yes, mischief, some deception.
What do you think would be the likelihood of if we reversed that and used medicinal cannabis as first-line therapy and added drugs to refractory patients that didn't respond to cannabis?
Brilliant. I think that's the way to go. But it requires a belief and an understanding that cannabis will do no harm.
Right.
And as long as the conversation is saying this is a dangerous substance, we have to be very, very careful. It may cause brain damage. It may cause all these problems that are alleged. That's not going to happen. But if you come to the place with really a critical review of the evidence and say, no, we're not seeing any harm, this really should be a first-line drug. It's an herbal medicine. Why not try it first? And then follow that with the AEDs, the anti-epileptic drugs, and be able to improve greatly on being able to control these seizure disorders.
I live for the day that this plant is freed, and I live for the day that we reverse that way that we're approaching medicine. But, you know, as you say, we give the plant, we give respect to the variety, the cultivars of the plant, and we have knowledge of general practitioners and specialists to be able to say, let's try these ones first that may be more suited to you, and then we'll reintroduce. I live, I dream for that day. Jeffrey,
I do too. That's wonderful.
Yeah, Jeffrey Hergenrather, thank you so much. I could talk with you for hours because there's such a wealth of not just expertise but care.
Thank you so
with what
much.
you've done. So thank you for joining us on FX Medicine.
Thank you.
This is FX Medicine. I'm Andrew Whitfield Cook.